Hi, Patrick.
What's going on? Good morning.
Good morning, good evening. All right, so I guess in the interest of time, we might just get started. So our next session will be run by Professor Patrick Hughes. So Prof Hughes is an Associate Professor of Emergency Medicine in sunny Florida, as you've just heard. He's also a faculty member of the Masters of Education in the Health Professions program at Johns Hopkins. And he has a really strong interest in medical education and also simulation. And he's going to speak to us today about innovative evidence-based instructional strategies and also coaching. So over to you, Prof. Hughes.
Thank you so much. Appreciate it. So just to kind of figure out who all the audience is everybody an emergency medicine physician that's involved in resident education and medical student education? Is that kind of the overarching theme of the people here? All right. I see a lot of head nods, thumbs ups. All right, looks good. So people are hopefully properly caffeinated. I would have a cup of coffee, but it's, I think, more appropriate to have a beer at this point in time where I'm at. But all right, let me share my screen. All right. So today I'm going to be talking to you guys about integrating innovative and evidence-based instructional strategies into medical education. So the objectives today are to define the characteristics of what you find in an ideal teacher, identify educational theories forming the basis of these innovative instructional strategies. So we are going to dive into a little bit of educational theory. I know that's nobody's favorite topic, but we'll do it early, hopefully painfully for you guys. Then we're going to discuss different innovative instructional strategies for teaching in not only simulation, but also the emergency department. And then how to apply these instructional strategies to overcome teaching challenges that you may face with learners. And then we'll demonstrate how to apply rapid cycle deliberate practice to actually virtual education if you guys are doing that sort of thing. So, what are the characteristics of an ideal teacher? This is open to everybody, not all at once.
To be a knowledge expert on their particular area they're trying to teach.
Okay, so knowledgeable.
I think engaging and able to adapt to the needs of their learners.
Okay.
This is a new thing that I've learned, able to actually adapt to different learning methods of your students or your trainees.
So I caught that right. Being able to adapt to different learning styles of your students. Is that what I heard?
Yes.
Okay.
Be an active learner during the teaching process.
Yeah, right. Be involved.
Be able to identify the learning needs of your students.
Okay.
I think kind of having a genuine interest in wanting your learners to actually succeed and kind of, just wanting them to have a good outcome, whether it's learning or feeling good about at least the bits that they didn't know or wanting to be motivated to learn more even after the session is the goal that I have.
Yeah, that's definitely, super important. So, of these photos here, do you guys have any particular, I guess this guy over here seems pretty intense. I'm sure we've all had, instructors that are similar to that in our medical education. I think a lot of you guys are naming characteristics maybe of what you see in this bottom picture here. And then does anybody know who this guy is right here? I see Mark nodding his head.
It's Don Talbot, who was the head coach of the Australian swimming team.
Yeah, I mean, anytime you have the name coaching magician, I think that's always probably like a good thing to be associated with you. So You guys have a very strong swimming program, so it sounds like he's pretty responsible for a lot of that. So yeah, right, setting expectations. You also want to listen to your students without interrupting them. You know, the average, I think I read something that the average person listens for approximately 1 second before interrupting the patient or the learner. So just giving them a chance to, you know, get out what they're going to say before interrupting them, because they may get to the point you want to make, you know, if you just were to listen for a little bit longer. Focusing on the learner, right? Being enthusiastic. I heard that. Being active. Knowledgeable, yet humble, right? Nobody wants the teacher that is really knowledgeable and all they ever talk about is how smart they are and how much smarter they are than everybody else, right? So being able to be knowledgeable on that subject matter, but also be humble. Act as a facilitator. So this is something we're going to kind of dig into in educational theory and why sort of this teaching style, being a facilitator for your learners is so important. So does anybody know what divergent questions are? So you have convergent questions, you have divergent questions. So a convergent question is something that your learner can answer yes or no. So you aren't able to dig into their thought process at all. You aren't able to figure out why is the learner making the decision they're making and going down the path that they're going down. So this is, you know, being able to ask them some sort of open-ended question that you'll be able to kind of get a peek inside sort of their processes about why they're making the decisions they're making. Another huge thing for our learners, right? Giving feedback, and objective feedback, you know, not, you did great today, you know, that doesn't necessarily mean a lot, right? So we're gonna kind of talk about that today also, how to give good feedback to your learners. Also, you know, be accepting of feedback. You know, just because you're the teacher doesn't mean you know everything. And, we're all going through continuous improvement. And I think this is something that, you know, being able to give and take feedback is important. And then as we all know in emergency medicine, you know, autonomy versus support. So your medical students may need more support, right? You can't just tell them, hey, there's a patient in septic shock with the BP is 60/30, in respiratory distress in room 1, just go in there, I'll be in 5 minutes. The patient will be dead before you get there. Whereas your more advanced learners, you know, you should be able to have the confidence in them. They need more of that autonomy and trying to find that balance, because if you don't give your learners autonomy, at some point in time, you're hindering them. So we'll talk about that too. So educational theory, I'm sure some of you guys, when you think of educational theory, are like this gentleman in the front row. Others of you guys are like the 10 over here, crying, not excited, but we're gonna make this hopefully more like 0 here on the FACES pain rating scale. But it's kind of just to give you guys some sort of a background into the things we talk about as innovational educational strategies, you know, why we do the things we do, and to give kind of a little bit of basic background for that. So does anybody know who these two gentlemen are?
Guy on the left is Piaget, but I only know that from the last lecture.
Oh, well, there you go. Perfect. I wasn't sure if you were like, secretly, just knew all your psychologists or whatever, you know. From the poster as a child that I had in my room, yes, it's Piaget, yes.
It's Vygotsky said.
Yes. So Jean Piaget is the guy with the hat on the left. He's a Swiss psychologist that it sounds like you guys talked about a little bit. So he's sort of the father of cognitive constructivism, which has led to a lot of the sort of modern learning theories. And then Vygotsky on the right, he is a Russian psychologist, and he kind of focused more on the collaborative nature of learning. So we'll talk about kind of both of them and sort of how that builds into this. The other cool thing about Vygotsky is he actually also came up with this theory called the zone of proximal development, which is used a lot in simulation. Do you guys know what that is? I don't know if anybody else has talked about that or not. So the zone of proximal development is, so for instance, when you're teaching your learner or doing some sort of education, it's making sure that he kind of has this theory that, there's what the learner knows at the center, and then there's this space around it, where the learner can get with some help or some scaffolding and build that. And then then the outer part is a part that's unattainable for your learner. So if you design educational questions or, for instance, simulation cases for your learners, and they're in the most outermost ring where it's not attainable for your learners are going to shut down and not be kind of willing to take that step and try and, participate. Whereas you kind of want to design your cases so that your learner doesn't know everything in the case, because then they aren't learning anything, but in that zone in between, that kind of sweet spot. So that's another one of his theories. So constructivism. So there's 4 parts of constructivism, and you'll kind of see how these are formed within the innovative instructional strategies we're going to touch on today. So the first one is that there's shared knowledge between the teachers and the students. There's shared authority between the teachers and the students. Teachers act as a guide or a facilitator. They're not just there to tell you what you need to do. And then lastly is that learning consists of small groups of students. So this is something that you guys probably see in the emergency department, or also kind of when you're doing your educational sessions, I assume, with the residents. So what's the average group size you guys have when you're doing education?
It probably varies between, 5 to 10 for us, and I guess other people might have, up to 20, 30 in the group. I don't know.
Yeah, it's pretty variable. I'd say anywhere between 5 and 30, depending on the bigger education days.
When you guys are teaching clinically, how many do you typically have on shift with you?
Well, I guess it depends on. Usually, if I'm teaching clinically on the floor, then in the department, then it's just like one-on-one. Or that might be like just a couple of people kind of hanging around.
Yeah, so for us, it ends up usually depending on sort of the time of year you have. So we have, kind of a 6-month time span where we get a lot of medical student rotators that are interested in emergency medicine coming through. And so on your shift, you may have a med student plus 1 or 2 residents. You usually have somewhere between, around 2 to 3 learners with you, which, can seem like a small group at times, but also can be difficult to teach that many people when you do have, sort of crashing patients or things that you need to be sort of paying closer attention to. So we'll talk about kind of some strategies on how to tackle that. So, all right. So next up is Kolb. No medical education lecture would be complete without David Kolb. So this is, what he built on was the work of Piaget and Gosky, and he created this cycle of experiential learning. So it starts with the concrete experience. So, this could be some sort of simulated experience, a real life experience. And then the learners move into the reflective observation phase, where they ask, what did I observe? What does this mean to me? And then they moved on to abstract conceptualization. And so they kind of use the insights gained through reflective observation to create an abstract conceptualization where, they say like, what principle seems to be operating here? What's sort of the general rule of thumb that you can apply from this experience? And then the last stage is the learner is active experimentation. So what are you going to do next time? How is this going to change what you do in the future? And, that's sort of the whole cycle. So, I don't know if this will play, maybe. So this is you guys doing your happy dance after we finished the educational theory part of this lecture. So now we can get on to the more fun topics, things that are applicable to you on a kind of daily basis. So this lecture is broken down into 2 sort of broad categories, and I'm going to let you guys pick, okay? This is kind of a choose your own adventure sort of lecture today. So on the left, you have numerous educational strategies: blindfold code training, error management training, stress inoculation training, mastery learning, deliberate practice, rapid cycle deliberate practice, that we can go through that apply more in the sim lab than they do in the clinical environment. And then on the right, you have some clinical innovative instructional strategies. So micro skills teaching, 1 minute preceptor, whiteboard pearls, post-it pearls, sampling observation, and a feedback card. So do you guys have a preference on which route you would like to go today? I don't know if people
go with simulation.
Clinical.
Clinical, sim.
Clinical.
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 Clinical. I'm hearing a lot of votes for clinical. All right. That sounds like that's an overwhelming majority wants to focus on clinical aspects today, so that's cool. So let me stop sharing real quick and pull up the clinical PowerPoint for you guys. All right. So now we're going to go through some clinical innovative educational strategies. So hopefully, some of these are new to you and you're able to sort of pull some pearls away from here and actually apply them on your next few shifts to provide better education for your learners. So, when you guys go to shifts, where do you start, right? So you want to start with assessing what type of learner are you dealing with. So is this learner a medical student? Is it an emergency medicine resident? Is this a resident that's a senior resident or a junior resident? And all these things kind of help guide sort of what kind of educational strategies you'll use in order to, number one, keep them interested, and number two, provide them with something that's tangible that they can learn from the shift. So next up is orienting the learner. So, this is something that you guys see, maybe medical students or residents that are, maybe it's their first day in the emergency department. They don't even know where the bathroom is. They don't know where room 1 is or room 10 or room 30. Or maybe this is a resident that, you've worked with, multiple times over the last month, and you know exactly kind of where their strengths and weaknesses lie. Kind of just talking to your learner about, what do you hope to learn from this shift? What is your goal from this shift? Is there anything that they want to practice, any skills they want to practice, any, types of patients they want to see, so that you can kind of help them work on those skills. And then, is your learner looking for any particular areas of feedback during this shift? So kind of starting out with sort of those basics, so that way you have sort of, an idea of what your learner is sort of looking for from this shift. Next, you want to set expectations. So what do we mean by that, right? How do you want your presentations? If your learner's just coming off an internal medicine rotation, they may give you a really long, drawn-out presentation because that's how they were taught on internal medicine to give a presentation. My goal for a resident or a medical student is for them to take no longer than 2 to 3 minutes max, giving me a focused presentation, right? Their differentials, they should focus on worst first. Maybe they can also give me their top 3 most likely what they think, is wrong with this patient. And then that way they go in knowing what you're looking for out of them. So you don't say to yourself at the end of the shift, why did this learner take 10 minutes, to give me a presentation? Or why did they spend 20 minutes in the room of each patient? I have residents now that I had to talk to last week. I had an intern and he kept going into the computer system. He'd spend like maybe 5 minutes before going to see each patient, looking through their record in the computer. If it's a complicated patient that's maybe nonverbal, I can see why you might want to do that. But some of these patients were simple. We were seeing them in the waiting room that were here for, vaginal bleeding or flank pain or, things that you go talk to the patient, you can get the information in less time than having to dig through their whole medical record. You also want to be clear with your learner up front. What are you going to be assessed on? Are you guys doing some sort of post-shift evaluation on them? Do you guys do, just 6-month feedback? Like, what are you specifically looking at? And what are you going to be grading them on during this shift. So that way those expectations are set kind of right up front. Also, charting, it's a huge thing, at least in the States, making sure that their medical chart reflects the things that are important, and charts how, you want the patient to be charted. So that way you aren't going back behind them and having to change so many things about each visit. So it's kind of setting all those expectations up front. Next would be priming your learners. So, with my junior residents, I like to just, we have a little face sheet that pops up on the computer, and it gives the chief complaint they come in with. So it's a 65-year-old male comes in with back pain. Okay, so you can ask your learner, all right, what are you looking for? What's on your differential before seeing it? Just based off the chief complaint. What kind of questions are you going to be assessing this person on kind of right up front? And that kind of primes them before they go in the room. So we talked about this a little bit before. So divergent versus convergent questions, right? So sticking more with the divergent questions, what do you think is going on with this patient? What else could be going on with this patient? How did you reach the conclusion that you reached? And what is the evidence for the conclusion you reached? Things like that to try and, get your learner to reveal sort of, what they're thinking, and not just can you, do you think this person's having an MI? Yes, no. Do you want an X-ray on this patient? Yes, no. Things like that, where, it really just shuts down the learner, and you don't really get to dive into, and see where maybe there's some of their gaps in knowledge, because maybe you just ask them a question they happen to know the answer to, but their clinical reasoning may be completely off on why they got the answer correct. And that's what we really want to avoid in medicine. All right, so now we're getting into sort of some more pearls that you can sort of take to your shift and are hopefully actionable. So this is something that's very popular. It's commonly taught in medical education circles. It's called the 1 minute preceptor, also called micro skills teaching. I don't think I've ever been able to get this done in 1 minute. I think it takes multiple minutes to actually do this, but the kind of 5 steps within it are: get a commitment from your learner. What's going on? What do you want to do? And then step 2 is to probe for supporting evidence. So, what supports your diagnosis? And then step 3 is you want to offer pearls, teach kind of general rules to the learners, and then provide reinforcement on what they did right. You did an excellent job of, doing a complete neuro exam on this patient, and then correct any mistakes. Next time, try doing X, Y, or Z with your patient. So this is kind of just an overarching general framework that I'm sure a lot of you guys use even without thinking about it when you're teaching your learners. Has anybody used this in the past or uses it currently? I see a few hands. So yeah, it's definitely something that's pretty common. The next one is micro skills of procedural teaching. So this basically takes what the 1 minute preceptor did and it pushes it into procedural teaching. So procedural teaching, a lot of people will break down into sort of 3 subcategories. So conceptualization, visualization, and verbalization. So conceptualization, so the clinical relevance of what we're doing. Why are we doing this procedure on this patient? Let's say you're going to put a central line in someone, right? Are they in septic shock and need pressors? You've already given them their adequate fluid bolus. What is the relevance of this? Visualization. So you want to talk to your learner about their familiarity with the procedure. Is this their 50th chest tube they're putting in, or is this their first chest tube? Maybe they put a chest tube in, but maybe they haven't put a pigtail catheter in, and now they're learning how to do that this time. And you can, and this is kind of the point in time that you can use sort of the just-in-time training if you have kind of a newer learner or someone that maybe isn't as familiar with the procedure, or you're doing a procedure that's maybe more scarce, and even you might not remember all the steps of doing that procedure, and just kind of have them brush up, watch a YouTube video on, how to perform that procedure. So that way, when you go into the room, that they have the steps kind of ironed out already and have gone through that visualization portion of it. Last piece of it is verbalization. So this is, when you want the learner to verbalize what they're doing and what they're going to do during the procedure. So that way you're kind of aware of the steps that are going to be happening. And then you can give them, feedback in real time and correct any mistakes before they happen. So, all right, I'm going to, introduce, put the ultrasound on, introduce the needle, follow it down to the vessel. Once I get a flash, make sure it's not pulsatile, feed my wire in, and have the learner talk through those steps. That way, you go in knowing like, okay, this is what the learner, you can feel confident that the learner knows what they're doing. You don't get into the room and just, you're like, oh man, this person has, no clue what they're doing. Now we're in front of a patient. Maybe the patient's awake. Maybe their, daughter's in the room and like staring at you and like, why is this person doing this procedure on me when they really don't know what they're doing, right? So it kind of helps avoid some of those, awkward moments you may run into. So the next one, this comes actually from Dr. Amal Mattu. He's at University of Maryland, and he is kind of one of the foremost emergency medicine minds as far as cardiology goes, but he also does a fair amount of medical education stuff. He actually teaches at the Teaching Academy for the American College of Emergency Physicians. So I got a chance to meet him, as well as he gave a grand rounds lecture to our residency maybe, 3 or 4 months ago. So, he's definitely one of those guys that you look to and kind of aspire to in emergency medicine. But one of the things sort of I took away from him was that he does this with his learners all the time. So they're called whiteboard pearls, or he also calls them sniper rounds. You guys have probably heard of this. Maybe not. So if I'm telling you all things you have heard, I'm sorry. But it's kind of fun to do. So as you can see in the pictures, he puts the room number that the patient is in on the left-hand side of the whiteboard. And then just one little pearl about that patient that you're going to take away from that case. So that way it kind of keeps the learning short, to the point. You aren't writing these massive things, but that way, at the end of the day, you can look back over this board and be like, wow, look at all these pieces of information that we learned as a team today, the things that we can take home. And that way, your other residents on shifts or other learners you have, maybe they're even on another team seeing other cases. As you can see here, on the right-hand picture, Mattu was on with this guy named Winters, who's a critical care EM guy at Maryland, and they split the board in half. And so Winters' team can see all the pearls that Mattu's teams are taking home as well. And that way, everybody's learning from all the patients in the emergency department and taking home, kind of all the knowledge that you can take home. So I think these are, something that we actually integrated into our emergency department. We have whiteboards next to every teaching station now, and this is something that I use on a daily basis. That's really helpful. And at the end of the shift, it's nice. I always ask the residents, hey, give me 3 pearls you took home from this shift. And it's something that they, because they've been going through this, they don't leave the shift and think, what did I learn today? I took care of a bunch of chest pain patients and belly pain patients and maybe some old, weak, dizzy people. And, maybe they don't think they learned anything from your shift, right? Whereas this clearly points out that there's a lot of learning going on in this shift. And, it kind of filters across all the teams. Because once, people walk by your whiteboard and see all this is being posted, I've had nurses, techs, a lot of other people in the emergency department reading the whiteboard and learning from it as well. And they'll ask you, oh, hey, can you tell me a little bit more about this point on the whiteboard or whatever? So it kind of gets sort of the whole team involved in the learning process. So I don't know, do you guys have whiteboards in your EDs?
Yeah, we started something like this, but not like a competition, which Amal has started now. But it's kind of died out, and especially with COVID, everything changed. And overall teaching, I'm sure others would acknowledge, overall teaching on the floor has taken a toll during COVID times overall. So we need to get back onto that, I guess.
Yeah, I feel like for a lot of us, it's definitely been, the last 2 years have been really fatiguing. And, you know, a lot of your shifts, you're just trying to make it through your shift, especially with some of the volumes, depending on whether you're in a surge or not. And so, you know, this is, you know, kind of something that it's simple. It doesn't take a ton of effort, but people, I think, get a lot out of this. And so it's just, you know, and I really like, because I used to have the students or the residents pick a topic, you know, so maybe they, you know, maybe it was syncope, or maybe it was, you know, aortic dissection, and then write on a specific topic on the whiteboard. But the hard part is that takes a fair amount of time. It's pretty involved, and they only really get, you know, one big chunk of information out of it. Whereas this, they're getting little pieces out of every single case that's going on around the emergency department kind of throughout the day. So if you don't have whiteboards in your emergency department, this is something that Michelle Lynn does. And they just use Post-it notes. So this is like the cheaper version of the whiteboards. And you can just find any wall, get some tape, put them up on the wall. And then that way it kind of has the same sort of, you know, function as the whiteboard, but just it's in a different format, I guess. So I don't know, has anybody here used Post-it pearls? No? But it's something cool, because then you can take any wall and turn it into, you know, a learning area. So, all right, next up, what if? So I don't know how many of you guys use this. I see some thumbs up. This is one of my favorite things to do with the resident. You can take any case and you can turn it into as complicated a case, as rare of a case as you want, and really dive into, you know, what the learner is, you know, maybe not seeing that day. So you have an ankle, you know, let's say you have someone that comes in with, you know, ankle pain. Well, maybe you turn them into someone that's immunocompromised, has a fever and a warm joint, or maybe you turn it into somebody who has a deformity and no pulse. You know, maybe you say, okay, well, now your patient has a penicillin allergy. You know what? And so you kind of just keep peeling back all these layers and making the cases into completely other things, but they get so much more learning out of each case, rather than it's an ankle sprain. I got, you know, an x-ray, it's negative, they went home, congratulations. You know, it can make it so that even if it is the, you know, 10th chest pain they've seen that day, that, you know, you're pulling additional information out of them, they feel like they're learning. So next, active observation. So you guys probably deal with this a lot when you're, you know, trying to monitor a student, a resident, maybe another resident, and, you know, you don't have time to go watch each person perform a history and physical, perform a procedure, because you're busy. Other patients come in. Maybe there's somebody that's unstable. And this is a way that you can sort of get a broader scope of the learner's skills without needing to be there for the entire H&P or the entire procedure. So you basically just say, like, okay, you know, this resident today, I'm going to go listen to, you know, through the curtain or through the glass from the patient. I'm just going to kind of stand out in the hallway, listen to, you know, a little bit of their history and see sort of what they're asking, kind of where their kind of mind is at with that patient. So that way you don't have to necessarily, hi, buddy. I know I'm in your room. I know. Benjamin, you want to say hi to people? Here.
Hi, people.
Hi, people. Yeah, hi, people. Say hi. Yeah.
Hi.
We have our in-laws in town, so they're sleeping in his room, so we moved his bed into the office. So it's like getting closer to his bedtime, so he like was going to say, hey, wrap it up, man, it's time for me to get in bed, you know. So Anyway, so back to sampling observation. So it's something that, maybe you go in and watch the initial part of, the chest tube or the central line or the intubation, but you don't have to be there, the whole entire time they're doing the procedure. And that frees you up to maybe go watch the student, do, their physical exam on, or their neuro exam on a patient. And then, the other thing that, is a big kind of focus in the United States right now is, patient satisfaction scores. So a lot of it comes to the discharge, the wrap up, how you deliver kind of the results to the patient, that sort of thing. So, we spend a lot of time going in the rooms with our residents and going over kind of how to discharge someone and make sure that they're doing a good job with it. So it kind of allows you to not necessarily, okay, this resident clearly knows how to take a history. This resident clearly knows how to do a neuro exam. Now you can kind of move on and check out different parts of them, but that way you aren't stuck in the room for, 20 minutes. And I do think, personally, I find it more advantageous to actually just stand out in the hallway, kind of outside of the curtain, and just sort of listen through, because then they don't necessarily know that you're there, and you can, I think, get a more accurate, description of what's actually going on inside the room. So do a lot of people do that already in their sort of teaching?
I don't do a sneak attack on them. But yeah, I will sample just part of their kind of interaction with the patient. Yeah, for sure.
But we don't realize we're probably doing it when we say, for example, we're giving them a WBA workplace assessment like a mini CX. And that's the time you're actually observing actively and then giving them feedback and listening to what, and depending on what task you've given them or what the task is for that. So I think kind of we might not be really cognizant of it, but it kind of happens passively most of the times as well.
But I think the concept of a sneak attack is interesting, because invariably when they know they're being observed, invariably, just from my memory of doing WBAs, it definitely impacts what you do and how you do it. So you probably, if they know you're observing, you're probably not getting kind of probably the information you're getting is a little bit different to reality. And I'm not sure how to kind of address that in context of, that's probably more accurate from an educator's perspective. But a little bit sneaky.
It's good though, because there's, you a lot of times find residents that, tell you, hey, I did an NIH on this patient. And did they really do an NIH? Like, no, they really didn't. And, they ask the person, lift their arms up, lift their leg up, lift their other leg up. Like, do they know where they are? Okay, you look like you're fine, And, whereas if you were physically standing in the room, for sure they would do every single step of that. And so I think it kind of gives you a little window into, sort of what the resident may or may not be doing.
I often actually ask them to just describe what you actually did, and sometimes it comes out, okay, well, that's where they haven't completed their sort of exam, such as they've done neuro exam, and when you actually ask them, have you done this, and they say, oh no, I've done this, gross, and not you. So that's another way to sort of.
Yeah, I feel like it's classic, right? They always say, oh, neuro exam, non-focal. Okay, well, what does that mean to you? How are you getting to that point, and what have you done to determine that it's a non-focal neuro exam? So yeah, that's excellent to ask what they actually did on the patient, for sure.
Particularly for examinations, I have pro formas that sort of auto-populate the text. And I go through it with my trainees and I'll go, these are the points that are important to examine. Have you done this? Have you done, And then I'll say, if this works for you, you can definitely steal my pro forma, but you need to be sure to go through all the bits every time. Otherwise, it's pretty meaningless.
Well, I think that happens a lot now with electronic medical records, where, you have like, okay, I have my, chest pain, physical exam already dialed in. I have my review of systems done for chest pain, and it kind of hits all the key points. But is somebody actually asking all those? You don't really know unless you ask them, because it just kind of auto-populates in the computer, and they may be doing only like a third of what they're actually saying in the medical record they're doing. So definitely things to keep in mind for sure. So, I mean, it's something that, we find often with, someone that comes with musculoskeletal complaint. Oh, I tripped and fell and I injured my elbow. Well, their review of systems has like 35 things checked off on it. It's like, really, did you ask all 35 things? Like, I doubt it. Like, you just clicked the box and it, auto-populated. So, things to think about. So, all right, on to the next topic. So feedback, right? How many of you guys, at some point in time have been given a good feedback sandwich where people smush, a good compliment and they put a bunch of, all the meaningful, actually probably accurate feedback in the middle, and then they finish it off with, some sort of good feedback. I feel like I've had that kind of feedback kind of throughout my career, and it never seems to be helpful. So, you guys experience that? Yeah. So kind of a way to get around that is to actually integrate something called a feedback card into your shifts. So, this is something that, I try and do with my residents at the end of the shift. Depending on how late we're getting out, you got to be a little bit cognizant of it, but I try to make sure I'm doing this sort of on a regular basis. So I want to first get their self-evaluation. How do they feel the shift went? Were there areas they thought, they performed really well today? Areas that they thought, needed improvement? And, I think from, once you start with the self-evaluation, a lot of times you'll find the residents or the learners are way harder on themselves than you. Like, you didn't even notice the thing that they think they did so terrible on your shift. And so I think, this is something that, allows, them to kind of come away from the shift, and you to come away from the shift too, and be able to, have the resident feel like they got something out of it, and that you were, like, hey, that really wasn't that big of a deal, but maybe do this instead next time. So self-evaluation, what was done right, what needs improving, and then what do you do next time? And then always ask the learner to summarize, the feedback that you gave them at the end. So that way, that they're actually, taking home what you want them to take home, that it's not like that feedback sandwich where, they don't really know the feedback that they got. The other thing with feedback is that, you want it to be objective, right? Use specific examples. And I try and jot this down throughout the shift, is that if there's something that I noticed that I'm going to give feedback on at the end of the shift, I try and keep a specific example of that. So that way at the end of the shift, because some residents, they accept feedback and, and they, are like, okay, but having that example, even the hardest people that don't want to take any of your feedback or think all you are doing is giving them incorrect feedback, if you have a specific example, it really highlights to them like, oh, you noticed this, you were paying attention, and it gives them some sort of concrete example that then they can work on correcting, rather than just throwing something out into the ether and, them not necessarily knowing what's going on. Also, give consistent feedback. So if you give feedback at the end of every shift, or the end of, maybe you notice you're working 3 days in a row with the resident, maybe give them feedback at the end of the shift and let them know that, like, hey, at the end of this 3 days, I want to sit down with you and have a discussion kind of about how this went. So that way they're prepared for that. Timely, certain things are best left not to the end of the shift. So if you notice some unprofessional behavior, something that's going on that, needs to be corrected in the here and now, it's a lot easier to correct at that point in time. A lot of the stuff can wait till the end of the shift, and that I think timely can also go to that, right? That they're getting, kind of feedback on a regular basis, rather than you give them feedback in their 6-month eval and they've been working the last 6 months with you and nobody said anything to them about, this specific thing that they were doing, wrong. Also try and give them something actionable. What can they do to actually improve this? Rather than just saying you did this wrong. Okay, now how are you going to, do this sort of better next time? Make it relevant to that specific resident and be clear. I find this kind of more with medical students, especially when it comes time for, we do these things in the States called standardized letters of they're called SLOs. They're like standardized letters of evaluation. And you need, when you apply for residency programs, the program, they get usually 2 to 3 of these from different programs they rotate through. So when you're applying to residency, other residencies can look and be like, okay, this is how they did on their rotation. This is sure they perform top 10%, top third, middle third, bottom third, or we wouldn't put them on our rank list. And this is a place that, you know, residencies should be able to give kind of unfiltered feedback about the learner to other residency programs. The problem with this, I have found, is that a lot of places will give a really bad feedback on this form, but they won't have told the learner, you know, during their rotation that they were doing anything wrong. And so then you get this, you know, medical student in an interview and you ask them, you know, like, hey, you know, this is kind of what's the general consensus about your work ethic or whatever. Nobody, and they say, well, nobody's, you know, told them that, or nobody gave them that feedback. So I think, you know, I always try to give the medical students, especially if they aren't doing a great job, by the halfway point of the rotation, I say, hey, this is all the feedback we've gotten on you. And, you know, these are things that, you know, we want to see changed in the next 2 weeks. Otherwise, this is what kind of evaluation letter, you know, our program will give you. So that way they go in eyes wide open. I can feel like my conscience is clean, that I'm not selling a bill of goods to other residency programs and saying, yeah, this is a top 10% resident. They get him, they match him. And then they're like, oh my word, you know, what did we do? So.
Hey, I'm here for the interview. Come on in, have a seat. You always bike to work?
No, sometimes I rock climb.
Why?
If my heart rate drops below 100, I'll get burnt out.
When did you know you wanted to go into emergency medicine?
Christmas Day, 5 years old.
Did you get something good from Santa?
A sleeveless Patagonia fleece and cargo pants.
What are your strengths?
I was born without a circadian rhythm.
What are your weaknesses?
Not ordering CT scans.
When's the best time to admit a patient to internal medicine?
Right after you order a big lab workup, but before any of the results come back.
What's the golden rule of emergency medicine?
If you can't diagnose it with ultrasound, it is not worth diagnosing.
What are 3 things you carry with you at all times?
Granola bar, ketamine, and overwhelming dread that I missed a potentially fatal diagnosis.
Where do you see yourself in 5 years?
Oh, severely burned out due to the crushing volume of patients who are unable to seek medical care anywhere else due to our corrupt healthcare system and widening income inequality.
Where do you see yourself in 10 years?
The same. I'll just be complaining about it more on social media.
I don't know if you guys have seen his videos. He does.
Hey, I'm here for the.
He does so many, you know, good videos that have, you know, kind of provided some relief during the pandemic for sure. So it's something that I think is hilarious. So, all right, I know we're kind of getting towards the end of the time. So, you know, you guys are aware of this. You know, in emergency medicine, there's lots of challenges we face with trying to educate our learners, right? You have lack of time. You're, you know, seeing a lot of patients in a short amount of time, many of them unstable, and still trying to teach at the same time. You know, you're teaching infrequently performed procedures. Patient members may be awake or aware of what's going on. You know, maybe you have an overconfident learner, an unprepared learner that shows up, or somebody that is just terrible at procedures. I had one of these residents a few years ago that I had to spend a couple extra days at the sim lab going through putting in central lines with. Also, how do you deal with complications, right? So there's all these things that we kind of, you know, go through in EM as we're trying to educate our learners. So one of the things that, you know, I would just kind of want you guys to take home from this is that make sure you use your resources. So what you maybe don't realize in the emergency department is you aren't the only person that can provide that education to your learners, right? We have podiatry residents in our emergency department. If I have, you know, a trimel fracture that needs to be reduced and splinted and the podiatry resident is in there, I let them go in with the EM resident and teach them the reduction and immobilization. You know, we have nurses and paramedics that do ultrasound guided IVs. So I don't need to necessarily go in and show them how to do an ultrasound guided IV or help them, you know, tweak their, you know, how they perform it. I can let the nurse do that. You know, do they know how to do a 12 lead EKG? The tech can show them how to do that. So there's other people you can leverage within your healthcare system to provide education to your residents, you know, while you're on shift. And I think that's something that, you know, maybe we I guess, don't use enough of in the emergency department. So in summary, did you guys learn anything today? What did you learn? And I guess, are you going to apply any of these techniques to your future learners?
I think I'll adapt some form of whiteboard pearls or post-it pearls in our department. I think that's a great idea.
So I learned this what ifs and the three things from one of Amal Matu's courses, and I use the what if all the time, but I'm struggling with the three things because there's always that time issue at the end of the shift and all. I started doing it, but then I've just lost track. So something to it. The what if actually gives a lot of satisfaction because you're giving that extra knowledge at the same time, and you can actually sort of see the reaction as well. So especially in fast track / urgent care centers where you have actually those common things and you don't really spend much time, as you said, the ankle injury, but then just expanding it a bit more and giving them another couple of extra things, what if, and then,
Patrick, there's a question in the chat room from Mana. Do you want to just ask it, Mana?
Oh.
So, I mean, just some quick tips here, like endpoint goals in terms of the rapid cycle deliberate practice and the virtual rapid cycle, like just your quick thoughts around that or any hints.
Yeah, so when we're doing, I tend to like to do rapid cycle deliberate practice in the setting where you have something that is, very prescripted, I guess. So like ACLS, right? Or things where, the team sort of can work through that. So I find that with our learners, I do a lot of RCDP, especially with medical students. I can pause the case, like I'm doing a trauma case with our medical students next week that I'm going to do with rapid cycle deliberate practice, because it allows, I can pause it, take a timeout, rewind, let them think about kind of what happened, being debrief on that specific small point, and then give them a chance to do it again. Whereas with our EM residents, I do it a little less because of the fact that I like them to have to deal with the consequences of their actions. But if you have, maybe, I guess, more junior learners or people that are maybe less experienced, I think it works really, really well. Virtual rapid cycle deliberate practice, we actually do over Zoom, and we actually have a Zoom room.
Ooh, I think we've lost. Have we lost voice with you, Patrick? No, everyone else can hear. Oh, must be just me. Sorry.
Patrick, and with rapid cycle deliberate practice, like, would you always plan to use it, or would it be kind of on the spot you identify a learning moment that is going to be well suited and you're going to then introduce that specific tool, or is it always kind of pre-planned?
So most of the time it's pre-planned. However, I have done it in the past. Like for instance, with the medical students, I originally wasn't going to use it. But last year I happened to be running sim cases with them, and the patient was dying so frequently, so fast that I just, it was almost disheartening to watch, right? And so, you think about it, you're like, okay, same thing with EM residents sometimes, right? If they make a big mistake, or they make something right up front and it's going to change the complete trajectory of the case, and they're going to get kind of the rest of the learning points, I think sometimes you can flip into it, say, hey, take a time out. All right, what did you guys do here? Kind of what was the thought process? All right, let's regroup, rewind this 30 seconds, start again, and give them a chance to kind of, revisit that part of the case for sure.
Another question we had earlier in the day was how to deal with diverse learners. So, the first year medical student in the group, and then also more senior trainees. Do you have any advice on that?
Yeah, so, sometimes you can do team teaching where, the senior can take a more active role in teaching the junior, or you can have them doing different parts that maybe require more skill or less skill, have them go to the room and have the senior, show the junior resident or the student how to do, a particular part of the exam, or, something like that. I can actually, I can forward to you, Mark. I published an article that you guys will probably find interesting. It's in Academic Emergency Medicine, Education and Training. It's like probably it's a long article. It's like 15, 17 pages. It was me and I think maybe 10 or 15 other EM educators kind of around the United States put together a list of, how to tackle different educational challenges. And one of those was that. So I can forward that to you and you can send it out to your group if you guys would find that helpful.
Yeah, that'd be great. There's another question in the chat from Lei Heng. I find it hardest to give negative feedback. How do you do that in learners or trainees that will motivate them, or in learners that you have told them 3 times to do something and they still repeat their mistakes?
Yeah, and it's hard, right? We all want to be liked in the emergency department. You work with these residents or these learners a fair amount. You don't want to be necessarily the bad cop. However, I always kind of frame it to them like, hey, I'm looking out for you. I'm trying to make you a better physician so that when you graduate from here, you're a good doctor. You're someone that is going to take good care of patients. That if my family member ends up under your care, that they, that I can feel comfortable that you're taking care of them. So I frame it more in the aspect of, I'm trying to help you progress and become a better emergency medicine physician. The 3 times thing, that's tough. I think a lot of times it's just getting down to, even if you tell them, the 3rd time, like, hey, you're doing this wrong. I think sometimes some learners need to process it and backing up and asking them, what was their thought process? Like, you noticed that they were doing this, using kind of more advocacy inquiry from SIM. Like, you noticed they were doing this, this is what they did. Like, why are they doing that? And then having them sort of tell you, so then maybe you can get to the root of it and sort of correct that.
Thank you.
Yes, being honest up front is definitely helpful. I think that's, knowing that so long as they know up front that you are an honest broker, that you give objective feedback, that you don't, you aren't giving them this feedback because you dislike them or it's anything personal, that, you're just like, once you're known as a person that is objective, gives, to the point feedback. I think a lot of residents really appreciate that. I find a lot of even, med students and residents, when they're at graduation, will come up and actually thank you for, helping mold them and make them better, because not everybody likes to give negative feedback or, constructive feedback. They'll just say, oh, you did a great job today, or, and just move on with their life. Or maybe they won't even give them any feedback. And so I think, it's sort of our role to make sure that they are getting that feedback. So when they're spread their wings and go on their own, they're, not the 007 that we don't want them to be, so.
All right, that was great. Thank you so much, Patrick. That was very useful, and thank you for answering all our million questions. Thank you.
Thank you.
Thank you, guys. Hope you learned something. Hopefully you can, institute this. And if you guys ever want to lecture on SIM stuff, I will gladly come back anytime. Just let me know. Thank you.
Thank you so much. And yeah, don't forget to send me that article. I think lots of people would like to see that.